Good morning to you all and welcome to the fifth lecture of the 2019 Palliative Care Lecture Series. Hospice New Zealand would like to thank and acknowledge Cancer Research Trust New Zealand for their generous support and funding to deliver these free lectures. The lecture today will be recorded and it will be available on the Hospice New Zealand website. Please be aware there will be an opportunity for questions at the end of the presentation. We would now like to introduce our guest speaker today, Dr. Rachel Wiseman, who is a consultant in respiratory and palliative medicine at Christchurch Hospital.
Thank you for asking me to speak today. My talk is on the role of oxygen in palliative care, which is particularly relevant because I work in both respiratory medicine and palliative medicine. So if we could move on to the next slide, you can ignore my spelling mistake on the title slide. Just to give you a bit of an overview about our talk today, I am going to run through a little bit of science, and apologies for that, but it is quite relevant to how you think about oxygen and how we use it on a day-to-day basis. Then go through the role of oxygen in the home, domiciliary oxygen, the various types, and walk you through some of the landmark papers in this area, as well as some of the burdens and bothers of oxygen in the home. And then at the end, just touch briefly on something which is relatively new, high-flow nasal oxygen, and the withdrawal of oxygen therapy. So to start with a little bit of science, the air that we breathe is actually predominantly nitrogen, and only 21% is oxygen, and a very small fraction is carbon dioxide. So we talk about the fraction of inspired oxygen, or the FiO2. So we're all breathing an FiO2 of 0.21 or 21% at the moment. And if you think about the lungs are a complex gas transfer system. Their role is to get oxygen into the body and carbon dioxide out of the body. Today we're going to talk about hypoxemia, which is the level or the partial pressure of oxygen in arterial blood. That's actually slightly different to hypoxia, which refers to the level of oxygen in the tissues, although some people do use the term somewhat interchangeably. So for most of us listening today, our oxygen saturations will be somewhere between 96% and 100%, which relates to a partial pressure of oxygen in arterial blood of 80 to 100 millimeters of mercury. But actually, when we're unwell in hospital, we know that giving people too much oxygen can be bad for them. So we used to give people high-flow oxygen when they came into hospital. For example, if the heart attack, we used to give morphine, oxygen, nitrates and aspirin, the acronym MONA. But we now know that the oxygen part of that actually increases mortality. Too much oxygen is bad for you. So the people in hospital, we actually target their oxygen saturations in a slightly lower range, between 93 and 96%, for those without underlying lung disease. If you look at the graph on the right, which might be filling some of you with horror and bringing back some memories of student days, this is the oxygen dissociation curve. So it's the relationship between your oxygen saturation and the amount of oxygen in your blood. If you look at the curve, it's got a flat part at the top and then a steep part further down towards the bottom. And if you look at the scale on the left-hand side, the oxygen saturation, and go up to 90%, follow that across and you're on the flat part of the curve. This equates to a pressure of oxygen in the blood of around 60-65 millimeters of mercury. So remember that number, 60 millimeters of mercury, because it comes important later on in the talk. And around the 90% level of saturation, a small change in your oxygen saturations leads to a small change in the amount of oxygen in your blood, because you're still on the relatively flat portion of the curve. If you come down to, say, 80% oxygen saturation, you're now on a much steeper portion of the curve. And so a small change in your oxygen saturations can lead to quite a large change in the amount of oxygen in the arterial blood. So So this is part of the reason why in those with chronic lung disease, we target their oxygen saturations in the 88 to 92% range. So we know that around the 90% mark is a safe level of oxygen in the blood. More than 60 millimeters of mercury oxygen in the arterial blood is enough to perfuse your tissues and to keep you alive and keep you well. That range becomes relevant when you think about the oxygen control system. And this is more correctly termed the carbon dioxide control system. Because although having a low oxygen level is a stimulus for you to breathe, actually having a high carbon dioxide level is a much stronger stimulus. Carbon dioxide is directly related to the acidity of the blood, and the body likes to keep that acidity in a very tight range. And so the body is very sensitive to changes of carbon dioxide because that alters the pH of the bloodstream, which then affects every chemical reaction that occurs in the body. So there are oxygen and carbon dioxide centers in the blood vessels, mainly in the carotid body and aortic arch. And then there are central receptors for carbon dioxide and pH in the brain and elsewhere in the body. This becomes important when you think about the group of patients who retain carbon dioxide. And this is often something that people come up to me and they're really worried about. So mainly COPD patients where their lung disease is such that the carbon dioxide levels in the blood are high. What this causes is that carbon dioxide sensor to become much less sensitive, so it's blunted. The body doesn't respond to changes in carbon dioxide as well because the levels have been high for such a long period of time. This means that some of these patients actually rely on having a low oxygen level as a stimulus to breathe. They're relying on something called their hypoxic drive. And in a small group of these patients, if you correct their oxygen levels, if you give them oxygen saturations of 95 or 96% by giving them supplemental oxygen, actually that removes the drive to breathe. And so their carbon dioxide levels aren't stimulating their breathing. The hypoxia is no longer stimulating their breathing because it's been corrected. And so their respiratory rate drops and they become quite sick. This is a real thing. I have seen it, and it's often corrected really quickly just by turning the oxygen down. But that's why there's the concern in people with chronic lung disease about controlling their oxygen therapy quite tightly. So if we target their oxygen saturations between 88 and 92%, we know that we're giving them enough oxygen. We know that's a safe amount of oxygen to give them to perfuse the tissues, but it's also not so much that it's going to remove that hypoxic drive, that drive to breathe. And that's often something people get quite concerned about. So you don't need to know if someone's a CO2 retainer, if they've got chronic lung disease. What you need to know is where you're targeting your oxygen saturations. So we're going slightly off topic, but this is a table of all the different things that drive the sensation of breathlessness. So we're moving slightly from oxygen into breathlessness. And really this table illustrates that there are many, many things that make you breathless. In fact, this table is taken from a whole paper on the causes of the sensation of dyspnea. Now, hypoxia or hypoxemia is mentioned a couple of times in that list, but it's not the strongest driver of breathlessness. And when you think about breathlessness, it's due, or dyspnea, it's due to an abnormality in the work of breathing, so the muscles having to work harder and do more, a chemical imbalance in the blood, which is predominantly hypercapnia, high carbon dioxide, rather than hypoxia, or a neuromechanical dissociation, a mismatch between what the body expects to happen and what actually happens. And this is where the emotional overlay comes in. Our bodies are programmed to breathe. Oxygen is essential. And when we can't breathe, when we can't deliver that oxygen to the body, all sorts of fight and flight responses occur because that is how we're programmed at a very primal level. I just want to spend a little bit of time on the symptoms of hypoxemia. So going back from breathlessness towards hypoxemia again, many of you will have been up to altitude where your fraction of inspired oxygen will be much lower. Most of you will have been on a commercial flight, particularly long haul, where the fraction of inspired oxygen is somewhere around 15%, because the cabin pressure is not pressurized to sea level. And for those of you who have been up really high, you might have experienced some of the symptoms of hypoxia. So you can feel quite tired. You can feel short of breath, but it's more a hunger for breath or breathing. You can sometimes feel quite euphoric, maybe a little bit nauseated. And I've done, when I was a registrar, tests in the laboratory where I've taken my oxygen saturations down to 80% and kept my carbon dioxide level stable. And it's quite an odd sensation. You feel this overwhelming urge to take another breath, even though that's difficult. And you do feel quite lightheaded and dizzy and slightly euphoric. I wouldn't describe it as an unpleasant sensation. It's just quite odd. If you contrast that with the symptoms of hypercapnia or a high carbon dioxide, it's quite different. Hypercapnia is often quite an unpleasant sensation. People are confused and agitated. They're often really twitchy and myoclonic. Headache is described, although it's not a common symptom of hypercapnia. If there is a sudden change in your oxygen level, then there can be some quite sudden symptoms, such as changes in levels of consciousness, seizures or coma. But the patient population that we see are the more chronically hypoxic, those with low oxygen levels over many weeks or months. What this leads to, this chronic hypoxemia, is a number of changes within the body. So it causes pulmonary vasoconstriction. So the pulmonary arteries are narrowing down. This eventually leads to remodeling of the arteries and pulmonary hypertension. And this causes right heart failure. It also causes peripheral vasodilation. So the blood vessels in the peripheries of the tissues are getting bigger in order to allow more blood flow and more oxygen to permeate the tissues. To compensate for that, the body has to push more blood around, which leads to an increased cardiac output and a compensatory tachycardia. So most of the COPD patients on the respiratory ward will run a heart rate of between 100 and 110, and that's pretty normal. Hypoxia also generates something called hypoxia-inducible factors, and these can cause erythropoiesis, so you get polycythemia for those who are chronically hypoxic. If you don't have as much oxygen in your bloodstream, perhaps having more hemoglobin to carry the oxygen is helpful. And they may cause chronic inflammation. And this may be relevant. Inflammation is very trendy at the moment. It's thought to tie into a number of different disease mechanisms and to perhaps increase mortality. And there's quite a focus on agents that have an anti-inflammatory effect, such as statins or macrolides. So that may or may not be relevant. What happens at the end of life? It's very difficult to know. There aren't many studies of what happens with oxygen levels towards the end of life. One of the largest I could find was a 2014 study by Bruera, who measured observations in a cohort of 357 patients dying in a palliative care unit. And there was a drop in oxygen levels in the last 3 days of life, but respiratory rate didn't change. A drop of more than 8% was specific but not sensitive for death within 3 days, so you couldn't use it to predict death. And when you looked at the group overall, nearly half had oxygen saturations of more than 90% prior to death, so still in that safe area where the tissues are being perfused. So although oxygen levels may drop, hypoxemia is not the mechanism of dying for patients having a normal death. So that's all the science for the day, you'll be pleased to hear. And we're now going to move on and walk you through some of the landmark papers looking at home oxygen. But before I do that, I just want to talk about some of the terms that you'll hear. So the most common one that you'll hear is LTOT, or long-term oxygen therapy. So this is home oxygen delivered with a cylinder and nasal cannulae, usually 1 or 2 litres a minute, for more than 15 hours per day. This is different to short-term oxygen therapy, which might be put in place for a few weeks for someone who's recovering from pneumonia or an exacerbation of their COPD in hospital, who just needs a little bit until they recover back to their baseline. This is different to short burst oxygen therapy, which is used to describe oxygen for a few minutes just prior to exercise or on recovery from exercise. And this is different again from ambulatory oxygen, so oxygen that you pull around with you whilst you're exercising, whilst you're out and about, whilst you're doing your ADLs. Nocturnal oxygen, oxygen overnight, and then palliative oxygen, so oxygen targeted to relieve breathlessness rather than hypoxemia. So the first thing we're going to talk about is long-term oxygen therapy. And the evidence behind this is actually now very old. It's based on 2 studies in the 1980s that showed increased survival in patients randomized to long-term oxygen at home. These studies are unlikely to be repeated now because this is considered a standard of care worldwide. And we don't know how this works. It's thought that it reduces the pulmonary pressures, so reduces the strain on the right side of the heart, which may increase survival. Looking at the 2 trials, the first was the NOT trial in 1980. And this looked at continuous or nocturnal oxygen therapy for patients with COPD. So there was no controlled group. You either used the oxygen overnight or you used it all the time. And the patients that used it all the time, when they looked at the use data, averaged about 17 or 18 hours per day. It was targeted at hypoxemic COPD patients with a pressure of oxygen of less than 55 millimetres of mercury. They screened over 1,000 patients to get 200 to enter the trial, and they followed them for at least a year. They were using between 1 and 4 litres per minute of oxygen therapy, and the mortality difference was quite big. So at 12 months, there was almost a 10% reduction in mortality between the nocturnal oxygen group and the continuous oxygen group. And the number needed to treat was 6. So if you treat 6 people with continuous oxygen for 12 months, you would prevent 1 death. In medical terms, that's actually a very low number. Shortly after this came the MRC trial in 1981. And this recruited COPD patients under the age of 70 and gave them oxygen for more than 15 hours per day or no oxygen. The numbers were much smaller. So in the oxygen group, there were 33 men and 9 women, and similar numbers in the control group. And they followed them for longer, for at least 3 years. They again showed a reduced mortality, but in men, this effect was only apparent after 500 days of treatment, so after 18 months of treatment. In women, the effect was apparent much earlier, but remember there were only 9 women in each group. So after 5 years, the mortality reduction was 21%, and their number needed to treat was 5, so again quite low. So on the basis of these 2 studies, domiciliary oxygen therapy came into practice. But there are a number of criticisms. Smokers were not excluded from these studies, and high proportions smoked. We don't actually know what the effect of oxygen therapy is in smokers because carbon monoxide produced by smoking bonds very tightly to hemoglobin, much more so than oxygen. And it falsely elevates your oxygen saturation levels. The numbers in these studies are relatively small compared to modern studies. If these studies were published today, they likely wouldn't be enough to change practice. And yet they both took an incredibly long time to recruit. They were difficult trials to perform. There was no quality of life or breathlessness data in these studies. It was purely powered for survival. So what is the current practice? Well, the current practice is that to receive domiciliary oxygen therapy, you need to meet specific criteria on an arterial blood gas. So you need to have a PaO2 of less than 55 or less than 60, that safe number, if you have evidence of right heart failure called pulmonale. That doesn't have to be an echo. It can be evidence of peripheral edema, a loud second heart sound or right ventricular heave. It can be ECG changes, anything that would suggest that there's strain on the right side of the heart. We tell people that they need to use their oxygen for at least 15 hours per day, 8 hours overnight, and then another 8 hours through the day somewhere. And the indications have extended beyond COPD to anyone who meets those blood gas criteria. So any chronic respiratory disease. There are some quite large observational studies. There's a large registry of patients on home oxygen in Sweden that show the survival of patients with COPD on long-term oxygen therapy is 2.4 years. And for those with interstitial lung disease, it's much lower at 0.9 years. So the next question is, well, okay, if there's a benefit for patients who are very hypoxemic, what about those who are only moderately hypoxemic? And in 2016, there was a large trial published called the LOT study, which is the group that ran this study, looking at moderate desaturation in patients with COPD. So stable COPD with a resting oxygen saturation between 89 and 93, so in our normal target range, or moderate exercise-induced desaturation, so between 80 and 90% on a 6-minute walk test. And a 6-minute walk test is exactly that. You ask someone to walk as far as they can in 6 minutes. Initially, they just wanted to do those with resting saturations in the 89 to 93 range, but they found that the recruitment was too slow, and so opened it out to those with exercise-induced desaturation. And it was a big study. So 368 patients in the oxygen group, 370 patients in the no oxygen group, the control group. For those with resting desaturation, they gave them oxygen 24 hours a day. For those with exercise-induced desaturation, they told them to wear it overnight and during exercise. And this multi-center trial took many years to recruit. They followed them for 18 months. There was no significant difference in survival. There was no significant difference in first hospitalization. There was no difference in quality of life, anxiety, depression, or measures of functional status. So it was a very negative trial. What was interesting for me reading that is that there were 51 adverse events. So remember, 368 people in the oxygen group, 51 adverse events, 23 patients tripped over equipment, 2 of them needing hospitalization. 5 patients reported a total of 6 burns. So 1 patient managed to burn themselves twice, 1 of those requiring hospitalization. That's not an insignificant adverse event rate when you look at the total numbers. So the next question is, okay, well, if oxygen works for people who are really hypoxemic, but not for those who are moderately hypoxemic, what about those who drop their oxygen saturations when they're exerting themselves? And we've already seen in the last study that that was a negative trial. And essentially in COPD, there's no evidence for ambulatory oxygen for those who desaturate on exertion only. My advice would be, don't measure oxygen saturations when someone exerts themselves. Only measure at rest. For those people on long-term oxygen therapy, most of them don't need portable oxygen. They use their oxygen for 16 hours a day, which means they get 8 hours off, essentially, and can go out and about in those 8 hours. Yes, their oxygen saturations might be low, but usually most people can tolerate that. Portable oxygen is a bit of a misnomer. The cylinders are really bulky. They weigh about 2.5 kilos. So to wheel one around with you is actually quite hard work, and to lift it in and out of the car usually requires a carer to do that. You can use portable oxygen concentrators like the little one in the picture. So it's a small box on wheels. And they are quite handy and quite useful, and you can plug them into your cigarette lighter. They're great for people who travel a lot or who get out and about a lot. There is a trial that's been published really quite recently on ambulatory oxygen for patients with interstitial lung disease. So interstitial lung disease patients are often really quite hypoxic, and on exertion can drop their sats quite markedly, sometimes into the 60s or 70s. And so if there was any group where ambulatory oxygen was going to be helpful, it would be those with interstitial lung disease. So this trial recruited those who desaturated to less than 88% on a 6-minute walk test. They gave them portable oxygen for 2 weeks and then observation only for 2 weeks. So there was no placebo group. They didn't feel that asking someone to lug around a cylinder of air was really fair. They instructed them to use it during activities of daily living, and they recruited 84 patients, and again, took quite a long time to recruit those patients. The primary outcome measure was a symptom score of breathlessness, essentially, and the scores improved, but were less than the minimum clinically important difference, so possibly not clinically significant. They measured activity levels and step counts, and it was no different when patients were using the portable oxygen versus when they weren't. But they also did some qualitative work with the patients. And actually, the patients gave really good qualitative reports of how they found the portable oxygen therapy. And 2/3 of the patients chose to continue after the study, which is actually quite a high proportion. So there may be some benefit to ambulatory oxygen in interstitial lung disease. It's just that it's very difficult to measure. This certainly wouldn't be the standard of care worldwide, but there would be some centres who would provide ambulatory oxygen to patients with interstitial lung disease on this basis. So that then brings us on to palliative oxygen therapy, which is, I guess, what most of you will be interested in. So oxygen for the relief of breathlessness. And the landscape was really changed by this trial, which was published, I think 2011 now. It's getting quite old. But it was quite a robust trial. It was randomized. It was double-blind with a placebo group. It recruited patients with refractory breathlessness from any cause, and the PaO2 of more than 7.3 equates to about 60 millimeters of mercury. They had to be breathless at rest or on minimal exertion, so the group of patients that we see in palliative care. They had to live for a month so that they could do the follow-up. They were given oxygen or medical air via nasal cannulae at 2 litres a minute for more than 15 hours per day for 7 days. So exactly what we would give someone with long-term oxygen therapy. And the concentrators were blinded. You couldn't tell the difference between an oxygen concentrator or an air concentrator. They randomized 239 participants over a number of sites, so around 100 in each group completed the study. They turned out to be mainly male COPD patients because they're the ones who are most stable and so most easily able to enter a clinical trial. And the baseline breathlessness score was 4.5 on a numerical rating scale of 0 to 10, and that's about average for breathlessness studies. When you look at the morphine studies, the baseline dyspnea score is usually around 5. The bottom line is that there was no difference in breathlessness scores between the oxygen group and the air group, and there was no difference in the quality of life scores between the two groups. But what was really interesting is that over the 7 days of the study, everyone felt a little less breathless, no matter which group you were in. So it wasn't the oxygen that was doing that. And it's postulated that maybe it was that security, that safety net of having a machine and the nasal cannulae, or maybe it's the flow of air across the face that's alleviating the sensation of breathlessness, just like we'd use a fan or an open window. But we don't know why the scores dropped. That study really has changed the landscape in terms of palliative oxygen therapy worldwide, and a number of international guidelines have now changed to say that in non-hypoxemic patients, there's no evidence for using oxygen to relieve breathlessness. So for hypoxemic patients, those with oxygen saturations of less than 90 or a PaO2 of less than 60, oxygen is usually still provided. Although in the palliative setting, we don't make them use it for 15 or 16 hours per day. But for those with oxygen saturations of more than 90, many services now will no longer provide oxygen for that patient group for the relief of breathlessness. So the quantitative evidence shows that home oxygen may have a role in mortality reduction for patients who are hypoxemic, and this is now the gold standard. Doesn't seem to have a role in moderately hypoxemic patients, those who desaturate on exertion only, or who are using it to palliate breathlessness. So why? Why do we still prescribe oxygen therapy? Because it's still out there and it's still used quite widely in palliative care. And it may be the sense that maybe there's a group of patients who do benefit. So David Curran in 2009 analysed a very large cohort of before and after breathlessness scores after the initiation of home oxygen. And overall the scores didn't change, but there was a significant minority who had an improvement in their scores. And it was very difficult to pick who this minority was. The qualitative literature perhaps answers this question a little bit better. There's a recent survey published by Natasha Smallwood in Melbourne looking at the views of palliative care and respiratory physicians around palliative oxygen. And about half of respiratory physicians and 2/3 of palliative medicine physicians felt that palliative oxygen relieved breathlessness. So quite high proportions, although that was lower than a previous survey in 2003. About half of physician trainees believed that palliative oxygen was useful for breathlessness, so similar proportions. So there's still a very strong belief out there that oxygen can palliate breathlessness, despite the Abernethy study showing that it did not. And when you look at the qualitative literature of healthcare practitioners, there's this strong sense that it works. Healthcare practitioners acknowledge that it's a crutch, but it helps the patient's anxiety. And, well, if it does no harm, it's just oxygen, then maybe that's okay. It makes us feel better. It's always what happens. So particularly in hospital, it's almost routine. You get popped on oxygen as soon as you come through the door of the emergency department. There may be pressure from family members to put someone on oxygen, to be seen to be doing something. And often healthcare practitioners are unaware of the dangers of oxygen therapy. Patients themselves are often also quite discerning, and their views are often shaped by previous experiences in hospital. So that experience of coming in, having the oxygen popped on and feeling better. They have positive views in that oxygen is an enabler for independence, it's keeping them alive, it's a tool for them to manage their breathlessness. And particularly those on portable oxygen, it did allow them to get out and about and avoid hospital and become more confident. But they also have a number of negative views in that it makes their disease more visible, and it's a sign of how sick they are. And remember that most of these patients have COPD. They're already quite guilty about their disease because they've smoked. And having that visible reminder of oxygen next to them can be quite difficult for them to live with. Many of them say it's not as good as I thought it would be. And that's quite a common theme. There's a stigma to the oxygen, an embarrassment or shame, and the equipment is difficult. Perhaps what's more interesting are the perspectives of caregivers. And if you have a caregiver, you are more likely to be prescribed domiciliary oxygen. If you don't have a caregiver, you're much less likely to receive it. And it was summed up by one qualitative study with oxygen givers and oxygen takers away. Caregivers see oxygen as a life-saving measure. It alleviates that feeling of powerlessness, that distress at watching their loved one when they're breathless. It gives them the feeling of safety. It relieves their anxiety. But there's also what was called the oxygen spiral. So watching their loved one become more dependent on the oxygen, watching the flow rates increase over time. There were financial and equipment costs. It's noisy and it impacted on social activities and was a barrier to travel. Another qualitative study who interviewed caregivers and patients showed that caregivers mentioned an improved quality of life on oxygen, but not the patients themselves. I think for the patients, it's more of a trade-off. So that brings us to some of the burdens of oxygen therapy. And it is a burden. When you look at the studies who've offered to continue oxygen for their patients after the end of the study, almost half say, no, thank you. So there was one, I think it was an Auckland study actually, of bottled oxygen versus air in COPD patients. And almost half in each group said, no, it's not worth it, you can have it back. And in the Abernethy study of palliative oxygen, 18% declined and said, no, thank you. 26%, yeah, okay, but I'm not really sure it was much use. It is a trip hazard. It does cause nasal irritation and nosebleeds. And you certainly can get over-attachment. I remember vividly one lady when I was a trainee who was out and about, going around her village, getting out of the house, and as soon as we put her on oxygen, she didn't leave the house anymore, because how could she possibly go out without the oxygen? It is noisy, and it's thought to cost about $25 to run an oxygen concentrator for 1 week, which is not an insignificant amount of money for some. It does impact the ability to travel. So if you think last time you were on an airline flight, your oxygen saturations were probably between 92 or 94%. It's about the same as being at the top of Mount Hutt ski field. They tend to progressively drop through a long-haul flight. So if you're going to get up and do something on a long-haul flight, like go to the toilet, go early rather than late. And tell people to make the most of the ground transport. You have to pay for in-flight oxygen, and the cheap airlines are more difficult to deal with and can often charge more. Your concentrator can travel with you, but it has to go in the hold. You can't take your own bottles on the plane because the regulators on the bottles are not certified, and you really don't want one of them to explode during the flight. It needs a doctor to fill out a form to say that you need oxygen. For patients already on domiciliary oxygen, on long-term oxygen therapy, they'll need an increase in their flow rate, usually of 1 or 2 litres a minute during the flight. For those who aren't on oxygen, if their oxygen saturations are more than 95%, then they shouldn't need in-flight oxygen. If they're less than 92%, then they definitely will need in-flight oxygen. If they're somewhere in the middle, you can do what's called a hypoxic challenge test. So you bring them into a laboratory and you get them to breathe air with an FiO2 of 15% and see what happens, or you can just use common sense. In terms of smoking, this is a big no-no. And the reason behind this is that nicotine addiction overrides common sense. Smoking rates do increase the risk of burn injuries. So in Denmark, where you don't have to be smoke-free to receive home oxygen, the burn rates are twice as high as Sweden, where you do have to be smoke-free. One review identified 55 patients, and although most burns were small, they cause serious injury, with over half of patients being intubated, and the mortality rate was really quite high. This is a sick group of patients. There was quite a frightening study from the USA that looked at deaths over a 7-year period, and 34 of those deaths were the patients themselves. 3 of those deaths were family members who were involved in the fire, and 1 was a non-smoker on oxygen therapy who was accidentally ignited by a family member who smoked. Most of these were at home, only 1 was in residential care, and most of the fires occurred overnight. So most people wear their oxygen overnight. It's when they get a lot of their 16 hours a day in. But it's also when you are more likely to withdraw from your nicotine. And so you wake up desperate for a fag. E-cigarettes are also contraindicated. So there's a heating circuit, a heating element in the e-cigarette, and it has been known to ignite oxygen. The cigarettes themselves have also been known to explode, and the charges as well. And so most services are not providing domiciliary oxygen to e-cigarette users for this reason. So I just wanted to spend a couple of minutes talking about high-flow nasal oxygen, because this has really taken off over the last 5 years, and it's something that particularly hospital palliative care teams will see more of. It's a way of delivering very high flow rates and very high FiO2 without using a face mask. So it uses oxygen mixed with air to deliver up to 60 litres per minute, and you can get your FiO2 up to 100%. The air is humidified and heated up between 31 and 37 degrees. You do need to keep your mouth closed for this to be effective. Basically, there's a circuit which involves an air-oxygen blender, a humidifier which then heats and humidifies the air, attached to some very fat nasal cannulae. And the advantages of this are that it reduces the dead space. So the dead space is the air in your main airways, so your pharynx, larynx, trachea, and main bronchi, which isn't contributing to your respiration and often doesn't kind of get exchanged in a normal tidal breath. And so putting high flow rates of air and oxygen in through the lungs flushes out this dead space. You're not rebreathing expired air. It can give you what's called PEEP. So it increases the pressure in the airways, which may prevent airways collapsing at the end of expiration. it's thought that airway hydration improves that mucociliary clearance and aids the clearance of secretions from the lung. What's the evidence? The evidence is probably a wee way behind the degree of use. It has been shown to increase the PEEP, the end expiratory pressure in the lungs, between 1 and 3 centimetres. So on a CPAP machine, your lowest setting would probably be 7 or 8 centimetres. So although it does that, we're not quite sure what that means and what effect that has on respiration. You can certainly give much higher fractions of inspired oxygen than nasal cannulae with much less variability. It's more reliable in terms of the FiO2 that you're delivering. And many patients find that humidification is quite helpful, although some people do find it too hot. There is evidence that it's helpful for people with acute respiratory failure. So compared to a non-rebreather mask or non-invasive ventilation, one study showed no difference in intubation rates, but a lower 90-day mortality and a more rapid improvement in breathlessness. After extubation on the ICU, it reduces the need for re-intubation compared to a Venturi mask, so it's used quite frequently on the intensive care unit. And there are ongoing studies in sleep apnea, heart failure, and during intubation. So it's quite widely used through the hospital setting. What that means for us is, particularly in hospital palliative care teams, you're getting an increasing number of consults where on the consult is, oh, they want to go home to die, but they're on 8 litres of oxygen. And then you're having to go in and negotiate about how you might manage that. And generally the first thing I would do is assess if they really need that flow rate, because most of them don't. It's just that nobody has ever tried to turn the flow rate down, or they're targeting an oxygen range which is too high. So if you reset your range to 88 to 92 and try and wean the oxygen down, often you can get them down to a low enough flow rate that you can get away with standard low-flow nasal cannulae. For those where you truly can't reduce the flows to less than 4 litres a minute, it is possible to give higher flows of oxygen at home. So each concentrator will usually deliver up to 5 litres a minute, and you can piggyback them together. There's just a wee Y connector that joins kind of the two sets of tubing together. So that will give up to 10 litres a minute. At those flows, nasal cannulae won't deliver the required flow rate, so you do have to use a face mask. And this increases the risk of rebreathing CO2 if you're expiring into the face mask and then rebreathing in that air. So it's something you just need to be careful of if they're becoming increasingly sleepy, agitated or twitchy. And at this point, you really need to stop measuring the oxygen saturations and focus on breathlessness. And that can be quite difficult for healthcare practitioners to do when we're trained to monitor oxygen saturations. So quite often, if we've got a patient like this on the ward, we'll actually bring the concentrators down to the ward, set them up with what they're going to use at home, and see if they can tolerate it, focusing on their symptoms rather than on the oxygen reading. For those who do have access, there is a device that can deliver high-flow nasal cannulae at home. It's called a MyAirvo 2. We've got a couple of the machines in Christchurch, but to be honest, we use them very rarely because in most cases you can get away with standard low-flow nasal cannulae. You can, just like the Airvo systems you see on the ward, you can vary the temperature. They still have to tolerate a face mask for about 99 minutes a day whilst the machine goes through its cleaning and drying cycle. And again, there's a cost to running one of these. So if you're running 2 concentrators and an Airvo, that's a not insignificant amount of money. And they're really only suitable for those people who are bedbound because the leash or the length of tubing on the high-flow nasal cannula is quite short. So just touching briefly at the end on withdrawal of oxygen therapy. And just occasionally you do get patients who are truly dependent on oxygen where oxygen is life-prolonging. So there was one memorable case of a lady in 2015 with interstitial lung disease who was discharged to hospital-level care on oxygen at 8 litres per minute, so 2 concentrators and a MyAirvo 2 device. And after a couple of weeks in care, she requested to discontinue her oxygen therapy. She was sedated with morphine and midazolam, and she died about 5 hours after the oxygen was removed. So oxygen can become life-prolonging, and withdrawal is a realistic option for this group, as it's similar to withdrawing dialysis or ventilation. But it does feel more personal. When you think back to those views around oxygen, I think the smaller the device, the more personal it feels when you're withdrawing it from someone's care. There is an assumption that removal of oxygen will cause distress, although this is an assumption. When you think about the symptoms of hypoxemia with that kind of slight euphoria it can produce, it may not be as distressing as we think. But we do tend to sedate people prior to withdrawing the oxygen therapy. I've only done this a handful of times, and the key things I've learned is that invest time exploring this wish with the patient and their whānau. Ensure that everyone is on the same page, ensuring the healthcare team absolutely understand what's going to happen. The oxygen should be removed by a doctor or another senior healthcare professional, someone who's going to be able to sleep at night, and absolutely not the family. Death may not occur immediately, and it may be several hours after the oxygen is stopped before they die. So in summary, the evidence for domiciliary oxygen other than long-term oxygen therapy isn't great. If you've got someone who isn't hypoxemic, so saturations are more than 90%, just think about who you're palliating with the oxygen. Is it the patient? Is it the caregiver? Is it yourself that you're trying to make feel better? And we do use the placebo effect in palliative care. We do whatever we can to make someone's journey smoother. But I guess I would question if there was an alternative treatment with more benefit or less harm that you could use instead.
On behalf of Hospice New Zealand and the registered sites, we would like to thank Dr. Wiseman for sharing her time and knowledge with us this morning. Thank you everyone for listening today. We hope you have found the lecture interesting and informative. Have a lovely day.